Hello, Professor Fatima. Sorry for being late for the opening ceremony. And now we will start this session with Professor Fatima Cardozo. Okay.
Thank you for the organizing committee. This is a pleasure and honor to present a figure like Professor Fatma Cardozo, a very well-known figure in the field of breast cancer. Professor Fatma Cardozo will be talking to us about HER2-positive breast cancer, locally advanced. Professor Cardozo, please.
Good morning, everyone. I hope you can hear me well and also see my slides. If not, please let me know. And thank you very much for the kind invitation to be here and to discuss with you a very important subtype of advanced breast cancer, which is HER2-positive advanced breast cancer.
Professor Fatima? Okay, it's full screen now. Thank you.
Is it okay?
Yes,
Can I go on? Okay. All right. So these are my disclosures. And just to remind you that last November, we had the 6th edition of the ABC Advanced Breast Cancer Conference and Consensus Guidelines, and that we had more than 1,000 people joining us virtually. Unfortunately, it was virtually, but hopefully next year we will have ABC 7 face-to-face. And the reason I'm always mentioning the guidelines is because treating according to guidelines improves survival. When we look at the diagram of managing HER2 positive advanced disease, these are the algorithm. This is the algorithm of ABC5. So about 2 years ago, what are the main changes in these last 2 years? Is that we have moved trastuzumab deruxtecan as our preferred option where available for the second-line setting. The rest of the guidelines don't have a major change. Obviously, when we look at this diagram, we see that there are a lot of costly agents in it, and almost all anti-HER2 therapies are very expensive. Perhaps the least expensive is trastuzumab, for which we have biosimilars, but even the biosimilars of trastuzumab are not sufficiently lowering the cost, and this becomes very problematic in many areas of the world. So is it worthwhile to invest in the treatment of these diseases? All treatments are so expensive. This is real-world data coming from Germany, and you see that the gray line, which is the HER2-positive advanced disease, is now the subtype with the best survival, the best outcome, and it has a median survival of about 5 years, and it is not uncommon that some of these patients may live up to 10 years with metastatic disease. So it is worthwhile to invest, even if the treatments are indeed quite expensive. I'm going to go briefly through the initial messages just to remind us of the basics, and then discuss the latest results with the new treatments. So we have two main messages for this subtype. One is to start anti-HER2 therapy as early as possible, because this is the most important treatment and improves survival. The other was a paradigm change in oncology, and this is that we should continue to block the HER2 pathway even after progression, because if we stop blocking, the progression is much faster. There are several ways of doing this with different types of drugs, but even the most simple one, which is continuing trastuzumab beyond progression, is very beneficial and unfortunately not available in many countries. Now, the trial that has shown the benefit of trastuzumab is a very old trial back in 2001, but was the first one to show a substantial improvement in survival in the metastatic setting, giving trastuzumab in the metastatic setting an ESMO magnitude of clinical benefit scale of 5. Now, we have other problems that are good problems to have these days, is that some of these patients achieve a complete remission. And so the question is, for how long should we continue to give the anti-HER2 therapy? And the fact is that nobody really knows. I think most of us will tend to look at it as with endocrine therapy and start questioning if we should continue beyond 5 years. But there is no strong data to do that. But we believe it is very reasonable to stop after several years of sustained complete remission. Now, we are also very familiar with the dual blockade principle and the fact that two antibodies that link to different parts of the HER2 receptor provide a synergistic effect. This has been clearly shown in the Cleopatra study. You see here the final results with about 8 years follow-up and the substantial benefit in overall survival from 40 months to 57 months. So as I told you, more than 5 years median survival. This is particularly true for de novo patients, patients not previously exposed to anti-HER2 therapy, since only 88 patients in Cleopatra had previously received trastuzumab for the early setting. So that leads to two recommendations that are similar but a little bit different. One is for patients previously untreated, where clearly the standard of care is trastuzumab, pertuzumab, and chemotherapy. And the other one for patients previously treated, where we still consider the preferred option for first line, trastuzumab, pertuzumab, and chemotherapy, but we may discuss other options if patients have previously received trastuzumab with or without pertuzumab in the adjuvant setting or in the neoadjuvant setting. Now, the data to continue beyond progression is for trastuzumab, not for the dual blockade. We do not have good, strong data to continue with the dual blockade beyond progression, and it is not recommended to do so. However, we can go back to pertuzumab as we can go back to many agents already used. This is a busy slide, but it's from a poster presented at San Antonio in 2020. It's a Japanese study called Precious, and it's the reuse of pertuzumab many lines after. It still provides some benefit. This is just to the basic principle of continuing to block the pathway. It is better than not blocking the pathway at all. Now, how do we use the anti-HER2 therapy? With chemotherapy, or can we use with endocrine therapy if you have a dual positive ER/HER2 positive breast cancer? We know that the chemotherapy combinations improve survival substantially. I've shown you that in the Cleopatra study. What type of chemotherapy? First of all, for the HER2 positive, as for the other subtypes, we do not need to use two drugs. We just need one drug at a time. So sequential monochemotherapy is the one that is recommended. Because of Cleopatra and because of this dogma that we always have to start with a taxane, a lot of people think that we must start with a taxane, trastuzumab, pertuzumab. But we do have data that shows us that there is no strong data to tell us that taxane must always be our first choice. In Cleopatra, that was the case. But remember that 90% of those patients were naive of treatment. For patients who have received taxanes in the adjuvant setting, we have other options, such as vinorelbine or capecitabine, that are better for the quality of life and also have been studied with trastuzumab and with the dual blockade and provide as good or better benefit than a taxane. So what is recommended in terms of chemotherapy, if you're using just trastuzumab, start with the vinorelbine. A taxane is also an option, not my favorite, but vinorelbine is also a very good option, as is capecitabine. For later lines, you can combine trastuzumab with almost anything, including anthracyclines, particularly liposomal anthracyclines. When you are using trastuzumab, pertuzumab, we currently have data for docetaxel, paclitaxel, nab-paclitaxel, vinorelbine, and capecitabine. But I am convinced that we can combine trastuzumab, pertuzumab with basically all the chemotherapy as we do with the trastuzumab alone. Now, for the management of ER positive, HER2 positive, it's true that we can go with a combination of endocrine therapy and THER2, but we have never seen such an improved survival as we see with chemotherapy. So we reserve this treatment for very selected patients, and especially for maintenance therapy after a few cycles of chemotherapy. I am not going to go into the details for lack of time, since I wanted now to explore the other anti-HER2 agents and the latest results. So, as I said, what has happened in these last 2 years was the challenge of TDM1 as our standard second line. Up until ABC5, TDM1 was the standard second line, but now we have, and this was based on these two studies, Emilia and Teresa, showing overall survival benefit, in particular Emilia, for the use of TDM1 in comparison, for example, with capecitabine lapatinib. But we had the coming to the clinical practice of this new agent, another antibody drug conjugate like TDM1, but that has a different payload. In TDM1 is a tubulin inhibitor, in deruxtecan is a topoisomerase 1 inhibitor, a higher drug antibody ratio, and the capacity of having a permeable payload, which means that you can have the bystander effect. Now, the first study that reported was a phase 1/2, or let's call it a phase 2 extension study with 2 parts of trastuzumab in heavily pretreated, of trastuzumab deruxtecan in heavily pretreated HER2 positive disease. And what you can see is that we have a response rate, very high, 60% response rate. And this water plot that got a lot of people very excited. And the fact is that if we look at the previous lines of therapy, these patients had received on average 6 previous lines of therapy, so really heavily pretreated. However, 2 points for this trial is that we didn't have any long-term outcome like PFS or OS, just a response rate, and we saw a potentially fatal side effect of ILD, or interstitial lung disease pneumonitis, in this small study for toxic deaths. You also see on the bottom that there are other side effects associated with trastuzumab deruxtecan, such as GI, alopecia, very important to tell the patient, and I'll come back to these side effects. So the second study reported was a head-to-head comparison of deruxtecan with TDM1, most of it as second-line treatment. And in this case, what you can see is that the majority of patients had previous 1 or 2 lines. So it means that they received these as second or third line, almost 50% as second line. They had all received trastuzumab, 60% had received pertuzumab, and some others have received other agents. And you see these curves that also got everyone very enthusiastic about this drug. This is the primary endpoint, which is PFS with a substantial improvement, and also more importantly, the overall survival also showing about 10% benefit in terms of 12 months overall survival rate. So this has changed then the landscape. while we are still waiting for overall survival, mature overall survival data, we do see a substantial benefit. And now TDXD is challenging TDM1 in the second line. Also important from this study is that we have learned how to monitor and act very early on with the lung toxicity. And if we do that, we can avoid toxic deaths. In this large phase 3 trial, there was no toxic death associated with ILD. But as you can see, there were still ILD noted. Now at ASCO, where we had this presentation, we also had an update on safety. And this is particularly important for us to discuss with patients. And what you can see here is that there is a substantial toxicity associated with this treatment. However, there are not a lot of treatment discontinuations. There are a few dose reductions, but not a lot of treatment discontinuations, which is a good sign. In terms of side effects that we need to discuss with the patient, GI is important. Look at how high is nausea, even vomiting for these patients. So it's very important. Something else that will impact quality of life is fatigue. 50% of patients have important fatigue, as well as alopecia. So please remember that an antibody drug conjugate is just a different way of giving chemotherapy. And so we do have side effects that are similar to chemotherapy, and we have to tell the patient that there is almost 40% of alopecia. And perhaps we can even test the ice cap. In this circumstance, we are doing that here in our institution. Also important to remember is that we need to use primary prophylaxis for nausea and vomiting. As you can see, it is substantially high if we don't use any prophylactic measures, and this should be done as we do for chemotherapy as well. And then for the pneumonitis, we have to follow the strict guidelines on how to monitor and how to intervene very early to avoid toxic deaths. So this has led to the new recommendation of ABC6 that says that trastuzumab deruxtecan is now our preferred option for the second line setting after exposure to dual blockade. If you do not have access to trastuzumab deruxtecan for second line, you can still use it later for heavily pretreated patients based on the data that I've shown you. And obviously, for those of you who cannot have access to trastuzumab deruxtecan, TDM1 remains the preferred second line option. Now, what other agents do we have? The HER2 CLIMB trial presented the data for the combination trastuzumab, tucatinib, and capecitabine. So dual blockade with an antibody and a small molecule. And this trial was particularly important because it looks specifically for brain metastases, not just stable brain metastases, but also what we call active brain metastases. So brain metastases that were either progressing or had not been previously treated. This started as a phase 2 trial, but was enlarged to become a phase 3 trial with a randomization 2-to-1. And what you can see here, not a very impressive result in PFS, but a very good result in overall survival with 4.5 months difference in overall survival. Also, the price to pay is higher toxicity with more diarrhea, hand-foot syndrome, nausea, and transaminases. And yes, these are side effects that can be associated with capecitabine, but please remember that capecitabine existed in the two arms, and toxicity was higher with the addition of tucatinib, in particular diarrhea, that needs monitoring, awareness, education of the patient, and early intervention. So here are the results regarding the specific site of brain. So response in the brain, and you can see that in fact there is a substantial response in the brain with the tucatinib combination. So this has made this triple combination of chemo, trastuzumab, and tucatinib a very preferred option for patients who have previously received trastuzumab, pertuzumab, and T-DM1. If you choose this one or deruxtecan is a matter still of debate. There are other agents that were presented and that we do not recommend their use. Neratinib and margetuximab, the results were very bad, either negative or almost negative, even if statistically positive, clinically not meaningful, and we should not waste our resources with these agents. So when can we use lapatinib? We do have strong data from phase 3 trials showing that combinations of chemotherapy trastuzumab are superior to combinations of chemotherapy lapatinib. This is level 1 evidence. It comes from, for example, this Canadian trial, taxane plus trastuzumab gives better survival than taxane plus lapatinib. And also from a dedicated trial called Cerebel that compare capecitabine, trastuzumab, lapatinib, capecitabine. And you can see that survival was better with trastuzumab, capecitabine. And this trial was done to say, or with the hypothesis that capecitabine, lapatinib was better for brain metastasis. And this was not shown here. And on the contrary, survival was better with trastuzumab. So in my point of view, there's only one situation where I use lapatinib in the metastatic setting is when I want to give a chemo-free regimen like trastuzumab, lapatinib alone without chemotherapy for heavily pretreated patients based on this trial that you see here that has shown a benefit in survival compared with trastuzumab alone. Now, in my last 2 or 3 minutes, I just wanted to highlight the problem of brain metastasis. Is not a problem just for HER2 positive, but it is particularly a problem for HER2 positive disease and has also specific management in this subtype. So we all know that multidisciplinary management for brain mets is crucial, and also crucial is local treatment. So whenever possible, we should start with local treatment. Surgery, if it is a single lesion, and we should complete this surgery with stereotactic radiation. And if not possible surgery, prefer SBRT, so stereotactic radiation, and leave whole brain radiation for the last resource when there is no other opportunity to treat. In terms of systemic therapy, you have a patient who develops brain metastases and the disease outside the brain is stable. You should treat locally and keep the same systemic therapy. We do not have a recommendation to change since the rest of the disease is stable. If the brain is the first site and the only site of metastasis, again, the guidance is treat locally with radiotherapy, and there is no benefit in restarting chemotherapy. It doesn't provide any benefit. But we do have data showing that if we should restart anti-HER2 therapy, for example, with trastuzumab. Now, with the results of tucatinib, we have to say that the triple combination is also an option for the situation where brain is the only site of disease. However, it may be better used later in the progression of the disease. We also have data showing that T-DM1 also is active in brain metastases from the Camilla study. And so this is also an option. This is the analysis from the Camilla study, an exploratory analysis, but showing that it is possible to obtain response in the brain with T-DM1. And later on, when the disease in the brain is progressing, then really my preferred option would be the triple combination with tucatinib, trastuzumab, capecitabine. And just to tell you that there is also data that deruxtecan can act in the brain. The data is not so strong as tucatinib, but there are data showing that deruxtecan can also cross the blood-brain barrier, especially after radiotherapy, and provide a response. So take-home message from the management of HER2-positive advanced disease, the biggest benefit, the most cost-effective is trastuzumab, and also continue to block the HER2 pathway even after several progressions. If we have to make a summary of importance, a must-have is trastuzumab or a biosimilar, and its use beyond progression. Very important to have would be pertuzumab. Very good to have would be TDM1, TDXD, and tucatinib. What is not recommended is neratinib and margetuximab, and lapatinib only associated with trastuzumab beyond progression, or if you don't have access to other options at all. So finally, I just wanted to leave the invitation for all of you to join us in Lisbon next year in November 2023 for the 7th edition of the ABC Conference and Consensus Guidelines. Thank you very much for your attention.
Thank you so much, Professor Cardozo, for this excellent presentation. Very elegant as usual. And I guess we have some time to entertain a couple of questions. Professor Gamal.
Thank you very much. My question about patient with metastatic HER2-positive breast cancer who received docetaxel, trastuzumab, and pertuzumab, and after 6 cycles of docetaxel, the patient achieved complete clinical response radiologically. Would you stop the chemotherapy and continue with dual anti-HER2? And what about the patient who achieved a very good response and did not achieve a complete response?
Thank you very much for that question, because I didn't have the time to mention that. There is an analysis of Cleopatra showing that there is no added benefit to continue beyond 6 cycles of chemotherapy and dual blockade. The majority of your benefit will happen in those 6 cycles. So usually I stop after 6 cycles, maximum 8 cycles, but it becomes very toxic, 8 cycles of docetaxel. So even if there is no complete remission, you have obtained the maximum response, you can stop chemotherapy and continue the dual blockade. If it is ER-positive disease, you can add endocrine therapy to the dual blockade.
Okay, one more question, Dr. Fatma, please. Regarding the TDXD, do you see that there would be a change in the guidelines for the sequence of treatment and it would replace TDM1 soon, or this is not yet?
I hope I told you that is the main change for ABC6. It has now become referred to TDM1 as second-line option. So after trastuzumab, pertuzumab. I know that we still don't have overall survival, and so that's why I'm saying that it's preferred, but it's not the standard of care. So it's still okay to use TDM1, particularly if you don't have access or you have limited access to trastuzumab deruxtecan. But because of the amount of benefit that you see in all the other endpoints, I am pretty sure there will be a substantial survival outcome benefit as well.
Professor Ayman.
Thank you, Professor Fatima, for your presentation, and it was amazing as usual. My question is, Cleopatra study was done before the introduction of pertuzumab as neoadjuvant and adjuvant. So when the patient become metastatic after neoadjuvant pertuzumab, trastuzumab, what line I will use? Pertuzumab, trastuzumab, or MBD1, TDM1?
Thank you. Yes, that is a very good question. And for me, in our clinical practice, what we do is look at the time of relapse. If it occurs in the very few years after the patient has received trastuzumab, pertuzumab, I would prefer to go with TDM1, or if you have access, with TDXD, for as long as pertuzumab was already used in the neoadjuvant setting. But if you have more than 2 years of disease-free interval, some people say 1 year. I think 1 year is debatable, but let's say you have a relapse 2 years after that, you can still use the dual blockade as your preferred first line. I would not use a taxane again. I would use, for example, vinorelbine, trastuzumab, pertuzumab, to save capecitabine when I give tucatinib.
If you allow me
Well,
just.
you want one question? اتفضل اتفضل.
As you said that trastuzumab deruxtecan become the preferred second line. So if the patient progressed after TDX, what is the options? Do you have any trials to see is TDM1 will work after trastuzumab deruxtecan or what?
So as you know, we don't have any trials on the population pre-treated with deruxtecan, because deruxtecan is just now becoming used in clinical practice. And this is clearly something where we need also real world data to see if the drugs, the other drugs, continue to be useful and efficacious after trastuzumab deruxtecan. If you want my opinion, I think they will, because the mechanism of action of trastuzumab deruxtecan is similar to TDM1. So it's also an antibody drug conjugate. And we now have data that after TDM1, you still have effect of trastuzumab, you still have effect of tucatinib, and you still have effect of pertuzumab. So I suspect, but I have no data, that the drugs will still continue to be efficacious, but probably less, because every time we go for further lines of treatment, the efficacy drops. However, again, I'll come back to what I said. It is very important to continue to block the HER2 pathway with whatever weapon you have available, because the moment we stop blocking the pathway and we give chemotherapy alone, the disease progresses very quickly and death occurs very quickly.
Dr. Cardoso, just going back to DXD and the impressive hazard issue already seen with the use of deruxtecan. In addition to the new data that we have from the Destiny about the low HER2, not the HER2 enriched, and in view of having lots of heterogeneous HER2 positive disease, do you see that in that area deruxtecan would be superior in the future over TDM1? Not only for its HER2 positive, but also for the HER2 low and the heterogeneity in the HER2 tumors. What do you see at this point?
So I wanted to say that please be careful with the hazard ratio. Every time we look at a new trial, please look at hazard ratio, which is the relative benefit, but also to the absolute benefit. It's very important that we look to both, and also very important to look at the toxicity. So from my clinical experience, deruxtecan is not an easy drug. So patients are really extremely tired. They do have alopecia as if they were receiving chemotherapy. There is this issue that you need to surveil the lung. So it's not so easy as to give TDM1, and certainly not so easy as to give trastuzumab, pertuzumab. So I think that we still have to go little by little to understand exactly where is the optimal line to use trastuzumab deruxtecan. At the current time, I think the appropriate line would be second or third. It depends on the amount of disease that you have and what has the patient received previously in the neoadjuvant, adjuvant setting, and in the first line setting. And again, I would be careful because these are mostly chemotherapy drugs. Here, trastuzumab functions more as a transporter of the chemotherapy agent. So I know everybody's excited about the antibody drug conjugates, but remember that they are substantially more toxic than the other anti-HER2 therapies.
This is a question about the patient who received the anti-HER2, and after that, the biopsy turned out to be negative for anti-HER2. What do you proceed? You proceed with anti-HER2 or you stop it after that?
So that was a very long discussion at ABC regarding that situation because it's a very difficult situation. So the first thing to do is to ask the same pathologist to look at the primary tumor and the metastases and make sure that there is no technical reason for a discordant result. If there is really a change in biology, and please note that that may happen for HER2 in only about 10% of cases, so there's not a lot of cases that can happen. But if it happens, the recommendation is that you can still try the anti-HER2 therapy because probably is what you just mentioned of heterogeneity of the cells. But you would have to give anti-HER2 with some other form of treatment, such as chemotherapy, for example. If there is no response, it is also okay to drop the anti-HER2 treatment. But if you have a truly positive primary HER2 positive, I would be a little bit worried of not giving any anti-HER2 therapy.
Professor Lubna?
Professor Fatima, thank you. Very comprehensive talk. My question related to TTXD is not an easy conjugated drug, but achieved a very promising effect. Is there any molecular marker can rely on it as a prognostic model, a predictive to select the proper patient for the proper treatment?
Thank you very much. And I wish I could say yes, but unfortunately there's not. The only biomarker that we have is the HER2 receptor. So we don't have any good biomarker to tell us which anti-HER2 treatment we should use. And this is why we have to continue research to try to understand. So the way I decide if I go immediately with deruxtecan or not, it depends on burden of disease, symptoms of the patient if the disease is giving too many symptoms, and also how fragile or not the patient is, and obviously always discussing with the patient what are the expected side effects. And we can always use deruxtecan, if not in the second line, in later lines.
Okay, in that case, we'd like to thank you so much, Professor Fatma Cardozo, for this very elegant presentation and for being with us. And thank you for your time and looking forward to see you in the near future.